A very good morning, everyone. I'm Dr. Pallavi from the Department of Neuroanesthesia, Neurocritical Care, and I'll be talking about Myasthenia gravis today. So, a 26-year-old female, non-smoker, non-asthmatic, known case of Myasthenia gravis on pyridostigmine 60 mg TDS came to emergency department with difficulty in breathing. She has difficulty in getting up from bed, no history of extraocular symptoms, no bladder bubble involvement. On examination, she was found to be tachypneic with single breath count of less than 8. On ABG, there was severe acidosis with PCO2 of 70, PO2 of 40, and gradual fall in saturation up to 80%. So a diagnosis of myasthenic crisis was made for this young lady. Let's dig deep into it and try and help her. So derived from a Latin and Greek word, myasthenia means weakness and gravis means serious, meaning a grave muscle weakness. It is the most common primary disorder of neuromuscular transmission. Estimated prevalence is found to be 14 to 20 per 100,000, affecting women more than men. Its incidence in children is found to be 10%. Women in their second to third decade are mostly affected, and men in their fifth decade. So, a normal neuromuscular junction where we have acetylcholine located in tiny vesicles in the presynaptic membrane. They are released into the synaptic cleft, which go and act on the acetylcholine receptors located on the postsynaptic membrane. Now, in a patient with myasthenia gravis, we have antibodies which are formed against these acetylcholine receptors. So the acetylcholine, which is available at the synaptic cleft, is not able to act on these receptors, thus inhibiting neurotransmission and causing muscle weakness. So there are two major categories of this disease. The one is a seropositive, where we have anti-acetylcholine receptor antibody forming 85% of the total group. This is mainly associated with thymic hyperplasia and thymoma. The other is a seronegative group, where we have antibodies like anti-MuSK antibody forming 5 to 8%, LRP4 antibody, anti-agrin antibodies. Now all these three proteins, MuSK, LRP4 and agrin, are actually responsible for clustering of acetylcholine receptors at the postsynaptic membrane. So the hallmark clinical feature of the disease is a fluctuating fatigability and weakness affecting ocular, bulbar and proximal limb weakness. It increases on exertion and typically improves on rest. The clinical feature patient can present with is ocular weakness, dropped head syndrome, neck extensors affected more than the neck flexors, limb weakness where proximal muscles are affected more than the distal ones, and face and bulbar, most commonly in MuSK type. The patient can present with dysarthria, dysphagia, difficulty in chewing, and limited facial expression, typically known as myasthenia gravis snarl. Coming on to the most important entity for us for the disease is myasthenic crisis. 15 to 20% of myasthenia gravis are affected by myasthenic crisis at least once in their lives. By definition, all myasthenia gravis patients with autoimmune or acquired form showing respiratory failure or muscle weakness and requiring ventilatory assistance. What are the precipitants of myasthenic crisis? It could be stressors like a physical stress, aspiration pneumonitis, infection, pregnancy, surgery, pain, temperature, extremities. Certain medication are also known to be the cause of myasthenic crisis like interferons, antibiotics like aminoglycosides, gentamicin, streptomycin, ampicillin, anti-epileptics, certain anti-arrhythmic drugs like procainamide and quinidine. So we have to rule out myasthenic gravis mimics before we actually reach the diagnosis of myasthenia gravis. The common ones are myopathies, dystrophy, mitochondrial myopathies, cranial nerve palsies like the third, fourth and sixth one, Guillain-Barré sir just talked about, Miller-Fisher variant, Horner syndrome, central nervous system disorders like parenchymal brainstem lesions, motor neuron disease and Lambert-Eaton myasthenic syndrome. So the laboratory testing we need to do for such patients is the radioimmunoassay, where we look at the antibodies, repetitive nerve stimulation test for which anti-acetylcholinesterase medication has to be stopped 6 to 24 hours before, A more than 15% decrement in the amplitude is significant. And another important test is electromyography, where single fiber is studied. It is found to be highly sensitive for Mysthania gravis. Edrophonium or the tensilon test comes next, where we give edrophonium in a dose of 2 mg, maximum up to 8 mg. There is a significant muscle improvement after the administration of the drug. Ice pack test, in which the patient with Mysthania gravis having ocular symptoms are known to improve after the application of ice packs. So the laboratory test for other associated disorders includes brain imaging, CT chest, chest x-rays, thyroid function test, pulmonary function test, immunoassay for SLE, rheumatoid arthritis and thyroiditis. Now therapies which are available to us for the disease is for symptomatic therapy, that is anticholine esterase inhibitors. Most commonly used is the pyridostigmine. Rapid short term where immunoglobulins and plasmapheresis. For chronic long term we have steroids and immunosuppressants, and the surgical treatment, that is the thymectomy. Now for pyridostigmine, the single dose is about 10 to 120 mg, and we have to be aware of the cholinergic crisis it can lead to. Prednisolone used in a dose of 40 to 80 mg, and we have to be aware of the gastrointestinal bleeding and the cushingoid appearance. Other non-steroidal immunosuppressants which could be used are azathioprine, mycophenolate, rituximab, which is gaining a lot of importance these days, methotrexate, cyclophosphamide. Also, we have the intravenous immunoglobulin used in a dose of 2 gram per kg given over a period of 5 days. So the management of myasthenia gravis in ICU will always be admission to the ICU first. If the patient has been diagnosed of myasthenia gravis previously, then we have to stop the anticholinesterase drugs because the pyridostigmine is known to increase oral secretion, which can further compromise our airway. These patients will need general critical care, avoid and treat systemic complication, evaluate for the bulbar and respiratory weakness, and see if these patients need ventilatory support. Search for the precipitating factor. Specific treatment like immunotherapy, plasmapheresis, IV immunoglobulins or corticosteroids are the next. So what should be the choice between IVIG and plasmapheresis? Now according to international consensus for the treatment of myasthenia gravis, it's said that it is purely based on the individual patient. For example, a patient with IgA deficiency or renal failure is not suitable to receive intravenous immunoglobulins. However, a patient with sepsis again is not a candidate for receiving plasmapheresis. But it is said that a patient when presenting with a severe form of disease, plasmapheresis is found to be more effective than immunoglobulins. When to intubate such patients? A single breath count of less than 15 minutes can be very handy in such patient. If we have spirometry available, then a 20-30-40 rule where forced vital capacity of less than 20, negative inspiratory pressure of less than 30, positive expiratory pressure of 40 could be used. Cardiac or respiratory arrest, any impaired consciousness, shock, life-threatening arrhythmias, severe blood gas alteration, bulbar dysfunction with confirmed aspiration, and whenever in doubt, just intubate these patients. BiPAP could be used to prevent intubation or reintubation of patients in myasthenic crisis. 20% of the patient in myasthenic crisis could be successfully supported with NIV. An independent predictor for NIV failure is hypercapnia with PCO2 of more than 45 mm of mercury. The common complication of myasthenic crisis in ICU, we have to be aware of a pneumonia, VAP, which is associated with 50% of myasthenic crisis patient, sepsis, deep vein thrombosis, C. diff colitis, and cardiac complication like heart failure or MI. The ICU care which we have to provide are aggressive chest therapy, bronchodilators like ipratropium are safe and decrease secretions, adequate nutritional support via enteral route as early as possible, and DVT prophylaxis, search and treat the precipitating factors. Now for weaning, maximal inspiratory pressure or sniff nasal inspiratory pressure could be used. Two interesting modalities which we have available are electrical activity of diaphragm, which can be assessed using a NAVA, which is not readily available everywhere, but something which is available everywhere is ultrasound, diaphragmatic excursion, can be a very important factor in weaning of such patients. For weaning failure, increased secretion, atelectasis, steroid-induced myopathies are some common factors. So this is a picture showing diaphragm in a liver window. Using the M mode, we can assess the diaphragmatic excursion. An excursion less than 10 millimeter suggests a weaning failure in a spontaneously breathing patient. So this is a proposed treatment for myasthenia gravis. If the diagnosis is confirmed, start with prednisolone. If there is, start with pyridostigmine, sorry. If there is no improvement, then prednisolone and azathioprine comes next. If still there is no relief, then mycophenolate, mofetil or rituximab could be used. If there is still no relief, then you have to go for off-label drugs. Now for a patient who's coming to us in crisis, intensive care management, IV immunoglobulin or plasmapheresis depending upon patient's treatment of infection and other precipitating factors. If there is no improvement with plasma exchange or IV immunoglobulins, glucocorticoids in high dose could be used, and if still there is no improvement, then rituximab can be given a trial. Now just to wake you guys up, which of the following characteristic best differentiates ocular symptoms in cholinergic crisis from the ocular symptoms of myasthenia gravis? Just one of you can raise the hand and tell me. Is it diplopia? Is it lacrimation, a muscle weakness, or ptosis? Lacrimation. Thank you. So all are true for myasthenia gravis except deep tendon reflexes are absent, decreased response to repetitive nerve stimulation associated with thymoma, antibodies against acetylcholine receptors. Thank you. So the first line of treatment of myasthenic crisis in our young patient should be plasmapheresis. Thank you so much. Thank you guys. Thank you.
Thank you, Dr. Pallavi.